Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We also have a Telegram group which you can join the group. It is very good for accessing all lecture related information. You can use the link to join the group. We have a Google Drive where all the PDFs of lectures are available and a master integration key by which you can navigate between the YouTube as well as the Google Drive. These are the disclaimers. And we are with phase 3, which is recorded pathology lectures. And today we are with Pursue 26 ZB1, which is dermatopathology and skin adnexal tumors, in particular the ECCRINE and the apocrine tumors. And we are streaming from the famous Chidambaram Diagnostics Center, Chidambaram, Kolkata, India. And to talk on today's topic, we have Dr. Sandyya Umamahesweran. She is an MD from JIPMER and a DNB. She's a consult pathologist and lab in charge of the famous Chidambaram Diagnostic and Scan. And her areas of interest is dermatopathology, cytopathology, surgical pathology, with multiple publications in international and national journals. She was awarded the DJ Reddy Memorial Prize, and she has worked as a senior resident in the Department of Pathology at JIPMER. So with this, I would request Dr. Sandyya ma'am, please start your lecture on ECCRINE and apocrine tumors. This is the continuation of various skin adnexal tumors. Over to Dr. Sandyya ma'am. Thank you so much.
Good evening all. This is part 3 of skin adnexal tumors, which will focus on ecrine and apocrine tumors. This discussion will be along the lines of introduction, histology of ecrine and apocrine glands, patterns of ecrine and apocrine tumors, classification of ecrine and apocrine benign tumors, malignant tumors, differential diagnosis, syndromes and other ancillary techniques. Sweat glands. There are 3 types of sweat glands, which are ecrine, apocrine and apoecrine, and these have slight differences. Ecrine glands are seen separately. They have a coiled secretory portion and a dermal portion, and then an intraepidermal portion. And apocrine glands are slightly bigger than the ecrine glands, and they're almost always seen in association with sebaceous glands and hair follicle. And the coiled portion of apocrine gland is slightly bigger as compared to ecrine gland, and they are seen in the subcutaneous fat. So, distribution wise, ecrine glands are seen throughout the body, but are absent in lip and glans. And ecrine glands are concentrated more in palms and soles. Apocrine glands, A for A, so it is seen more in axilla and anogenital region. So the function of sweat glands is regulation of body core temperature, electrolyte balance, parenteral or oral drug delivery to the surface of the skin, and to some extent the ductal epithelium of sweat glands are involved in wound healing. So we'll see in detail about ecrine glands. So as I said previously, ecrine glands have a coiled secretory portion deep in the dermis, and then there is a straight duct which is seen in the dermis, and a spiraled intraepidermal portion which is known as acrosyringium. So, as we saw already, the most important function of ecrine glands is thermoregulation, and ecrine glands are active from the neonatal period, and they are seen all over the body, but are most concentrated on palm, soles, forehead, and axilla. They have secretory and excretory function. These are convoluted glands with lumen. Cross section of these glands will look like this. There will be double layer of cells, inner cuboidal and peripheral myoepithelial layer. So the myoepithelial layers will contract and expel the secretions. And if you look at the types of cells, there are 3 types of cells in ecrine glands. Clear cells, which have a pale or finely granular cytoplasm with round nucleus, and these are rich in glycogen and dark cells which border the lumen of glands, and they have abundant secretory granules which are rich in mucopolysaccharides and proteins. Myepithelial cells are seen in the periphery, and they are contractile spindle cells that help in expelling the secretions out. So we see here these are the clear cells and there are these dark cells. These clear cells are important to note. They are rich in glycogen and they are seen in certain types of eccrine tumors. Apocrine glands. Apocrine glands are secretory glands located in the deep dermis and subcutis. They are slightly larger than the eccrine glands, and they're seen in association with hair follicle and sebaceous glands. Apocrine, the name means that the cytoplasm, part of cytoplasm is detached and is found in the lumen along with the secretion. If you notice here, in the lumen there is a protrusion. A part of cytoplasm is decapitated along with the secretion into the lumen. So apocrine glands are concentrated in axilla and anogenital areas and mammary region and in the eyelids and external ear canal. So histology wise, apocrine glands have one layer of cuboidal, columnar or flat cells surrounded by an outer layer of myoepithelial cells. So the luminal cells show eosinophilic cytoplasm and may contain lipid, lipofuscin, and nucleus is situated in the base of the cell. Immunohistochemistry wise, these apocrine glands are positive for GCDFP15, which is gross cystic disease fluid protein 15, and EMA. So myoepithelial cells lining the secretory sweat glands are positive for smooth muscle actin. What is the difference between eccrine and apocrine glands? Eccrine glands exist at birth, whereas apocrine gland, they also exist at birth but become active at puberty. Eccrine glands secrete watery sweat that is rich in water, sodium, potassium, ammonia, lactate, lysozyme, and DNases. Um, and apocrine glands secrete an oily, odorless substance rich in lipid, protein, and steroids. Eccrine glands are present all over the body except lip and glands, and they are more concentrated in palms and soles. Apocrine glands are present at sites rich in hair like axilla, anogenital region, and mammary glands. Eccrine gland secretes liquid without disintegration of the cell, whereas in apocrine gland, a fluid is secreted along with the tip of the cell, which is also pinched off. Enzyme histochemistry wise, eccrine glands are rich in phosphorylase and succinate dehydrogenase, whereas apocrine glands are rich in non-specific esterase and acid phosphatase. And apocrine glands are positive for periodic acid shift, and they have this PAS positive diastase resistant granules. So we'll move on to the classification of eccrine and apocrine tumors. So before going into the details of eccrine and apocrine tumors, I want you all to remember the 3 C's of sweat gland tumors, which is you expect clear cell change in certain tumors, and cystically dilated ducts are present which are reminiscent of sweat glands, which are, you can note these cystically dilated ducts in certain tumors, which will help you point towards a sweat gland differentiation. And there will be cuboidal or columnar cells in the luminal side of the ducts, whereas in the periphery there will be myoepithelial cells. Basically there will be 2 types of cells, and you commonly expect clear cell change in some of the tumors of sweat gland differentiation. So please remember the 3 C's of sweat gland tumors. So classification wise, there are benign and malignant tumors. So the new addition to this classification is nut carcinoma, which is nut carcinoma of appendigeal tumors. We'll see in detail subsequently. So before we discuss each and every tumor, I want you all to remember the pointers of ecrine and apocrine differentiation. So, when you look at a tumor and you expect it to be of sweat gland differentiation, most important thing is to look for the pattern of tumor, whether it is a cystic one, solid one, or solid cystic one, papillary pattern, mosaic-like pattern, or tadpole-like pattern, or a salivary gland tumor, a morphological picture resembling a salivary gland. There's a lot of relationship between sweat glands and salivary glands because two types of cells are present in both sweat glands and salivary glands, the secretory component and myoepithelial component, and so on. So certain types of sweat gland tumors recapitulate the morphology of salivary gland tumors, like chondroid syringoma that resembles pleomorphic adenoma of salivary gland, and so on. So most important thing is to look for the type of stroma here. And after you identify the pattern, then you focus on the types of cells. If you are able to notice two types of cells, whether there is a luminal cuboidal cells with eosinophilic cytoplasm, and if decapitated secretions are present, it is a marker of apocrine differentiation, and surrounded by a peripheral flattened layer of myoepithelial cells. Also, there may be presence of poroid cells in certain tumors, which are small cuboidal cells with round to oval nuclei, which are somewhat different from the usual squamoid cells, which are slightly larger. There may be presence of clear cell, squamoid cell, mucinous cells. After you notice the type of cells, please note the type of stroma that is present, whether it is a chondromyxoid stroma like that of pleomorphic adenoma, or hyalinized stroma, or fibrosed or desmoplastic stroma. So, depending on the types of tumors, these are certain patterns that are visible in certain type of tumors. You will understand more as we see each tumor in depth, but this is a blanket of classification where you can have cystic type of tumor. This pink thing here represents the decapitated secretions, which is a marker of apocrine differentiation. And this is a representative of solid tumor with cystic change, which could be seen in nodular hydroadenoma. And this is a jigsaw puzzle pattern where there will be a mosaic of blue basaloid cells, and there is another mosaic of blue basaloid cells that mold into one particular type of mosaic. So this type of picture is seen in cylindroma, and this is a representative of sheets of basaloid cells with ductal lumina enclosed in between. This type of blue basaloid sheets are seen in poroma, and this is the comma like ducts that are seen in syringoma, and these are epithelial cells and myoepithelial cells that are embedded in a chondroid stroma, which is seen in chondroid syringoma. So it will make more sense as we see each tumor in detail, but this is the basic. Always note the pattern of tumor first, and then the types of cells that are present in it and the stroma. That will help you to classify a particular tumor as an ecrine and apocrine tumor. So again, this is the same thing. When we were discussing sebaceous tumors and follicular tumors, we were focusing on hyperplasias, hamartomas, benign and malignant tumors. But here, we focus more on the pattern of ecrine and apocrine tumors. The cystic type of tumors that are there are hydrocystoma and cystadenoma. The solid tumors that are there are that manifest blue basaloid pattern is seen in poroma. Jigsaw puzzle-like pattern is seen in cylindroma. Tadpole-like pattern is seen in syringoma, and tubular duct-like pattern, which is seen in chondroid syringoma. So, and then salivary gland tumor, which is like mixed tumor. Salivary gland type of morphology is seen in mixed tumor, myoepithelioma, adenoid cystic carcinoma, secretory carcinoma, which have basically the morphology that are seen in salivary gland tumors. This is an interesting article, and which is a very nice article that will help you to understand and classify each type of tumor. And in this article, they have classified sweat gland tumors by 6 basic histologic patterns. The first pattern is dermal cyst with double cuboidal or columnar lining, which is seen in hydrocystoma and cystadenoma. The pattern 2, which is solid pink clear squamoid proliferation in epidermis or dermis, which is seen in acrospiromas, poroma, hydradenomas, and all. And the third pattern is blue basaloid proliferation in dermis, which is seen in spiroadenoma, cylindroma, and all. And tadpole paisley type pattern is seen in syringoma. And cystic spaces and papillary projections are seen in syringocystadenoma papilliferum and hydradenoma papilliferum and digital papillary adenocarcinoma. And dermal nodule with variable mixture of cords, chains, tubules, and chondromyxoid stroma is seen in mixed tumor, which is chondroid syringoma. Let us move on to the first entity in ECCRINE and apocrine tumor, which is the hydrocystoma. Hydrocystoma, as the name suggests, it's a benign tumor which is essentially cystic, and it presents as a solitary translucent cystic nodule. Grossly, it appears to have a bluish hue. It is more common close to the eyelids, and other sites where it can present are ears, scalp, chest, shoulders, and vulva. So histopathologically, there is a cystic space in dermis with papillary projection, and if you look closer, there will be a single layer of columnar or cuboidal cells with a snout in the apical snout, which represents the decapitated secretions, and these granules are positive for periodic acid shift and are diastase resistant, and these luminal cells are positive for CEA and EMA. The periphery has myoepithelial cells which are positive for S100. So hydrocystoma is a single cystic structure in the dermis with single layer of cuboidal or columnar cells, whereas cystadenofibroma is somewhat more complex in that there will be more layer of columnar or cuboidal cells, and the stroma accompanying it will be more fibrous. Hydradenoma. It is the commonest ECCRINE and apocrine tumor. You would all have encountered this name. It is synonymous with nodular hydradenoma or clear cell hydradenoma. It is more common in head and neck and limbs. It can essentially present anywhere. It is a well circumscribed benign dermal neoplasm. It is a lobulated solid cystic neoplasm. If you take a closer look at it, there are solid areas as well as cystic areas, and there are clear pale cells and polygonal eosinophilic cells. Like there are two types of cells, clear pale cells and polygonal eosinophilic cells. There may be mucinous, squamoid, and other cells, and in between there may be ductal cells. Ducts are entrapped in between, and the stroma appears to be hyalinized. These clear pale cells are abundant in glycogen. So these cells are positive for CEA, EMA, P63, P40, and CK5R6. A translocation that is associated with this tumor is translocation level 16 CRTC1 MAM-L2 fusion. It is noteworthy that this is the same translocation that occurs in mucoepidermoid carcinoma, another relationship to highlight between sweat gland tumors and salivary gland tumors. This CRTC1 stands for cyclic AMP regulated transcriptional coactivator, and this MAM L2 is mastermind like 2. Essentially, this fusion drives the cyclic AMP mediated pathway, which results in this proliferation of cells. So it is noteworthy that the relation between salivary gland tumor and sweat gland tumor comes out in this translocation. Another common tumor is pyridinoma. Spiridinoma usually presents as a solitary intradermal nodule, which is 1 to 2 centimeter in diameter. It is a benign tumor, so it is well circumscribed and sharply demarcated, mostly present in the dermis. There are two types of cells here. There are peripheral dark cells and there are central pale cells that surround a lumina. And the lumen seems to have some eosinophilic secretions. So these lumina contain again PAS positive diastase resistant material, and these luminal cells, they express CEA and EMA and c-KIT, and calponin and P63 are positive in the peripheral myoepithelial cells. Another noteworthy thing is the mutation that occurs in this tumor, CYLD mutation, which is seen in syndromic spiridinomas. It is associated with Brooks-Spiegler syndrome. We'll see in detail about this syndrome later. This syndrome is actually associated with multiple spiridinomas, cylindromas, and trichoepitheliomas. And here the gene mutated is the CYLD gene, which is actually lysine 63 deubiquitinase. It is involved in ubiquitination of lot of proteins and it is mutated in lot of tumors, cylindroma, spiridinoma, and all. So it is associated with Brooks-Spiegler syndrome. Another most common tumor is poroma, ecrine poroma. It is commonly referred as. It is a benign tumor. It is reminiscent, the morphology is reminiscent of intradermal portion of sweat gland. It is most commonly seen in palms and soles. If you recall, palms and soles are where the sweat gland, ecrine glands are most commonly concentrated. And poroma presents as a nodule, which is a smaller nodule, which is 2 to 20 millimeter in size, presenting in palm. There are two population of cells histopathologically. There are dark cells, which are poroid cells, which are called poroid cells, and pale cells with eosinophilic cytoplasm, which are called cuticular cells. And this tumor is richly vascular, like granulation tissue. There are lots of capillaries and areas of necrosis may be present. This is a pitfall here because we are trained to think that necrosis is associated with malignant tumors, whereas this is an exception, a poroma, which is a benign tumor that can have areas of necrosis. So this point is to be remembered. If you look at it, there are sheets of cells, anastomosing epithelial sheets arising from dermis. And if you see in the center, there are these pale cells or clear cells, whereas in periphery, there are these eosinophilic cells, which are cuticular cells. So here, the translocation is YAP1 MAML2 or YAP1 NUT-M1. YAP1 is yes associated protein 1 and NUT-M1 is nuclear protein of testis, which is the fusion seen in nut carcinomas and all. It is poroma also expresses the gene fusion. Here, CEA highlights luminal border of the ducts. I mean, if you see in low power, there are this sheets of blue cells, but if you look closer in high power, there will be lumina or ducts enclosed in between. So the CEA will highlight the luminal border of ducts. Always remember that if you see sheets of blue basaloid cell, it may point towards any of the adnexal tumor, be it sebaceous, sebaceoma, sebaceous adenoma, or follicular tumor, trichoblastoma, trichoepithelioma, or poroma, which is common. But there are these subtle morphological clues that will help you to identify it as a poroma, and one such thing is the entrapped luminal lumina of the ducts that will help you identify it as a poroma or a crine tumor. Next one is an interesting tumor, which is a hydracanthoma simplex. It is nothing but intraepidermal form of ecrine poroma. You see that this is the epidermis, and these are the squamoid cells. And if you see in the stratum spinosum layer, there is this proliferation of cells here and here. These cells do not appear exactly squamoid like the normal cells of epidermis. There is some difference. These cells are somewhat smaller, and the nuclei is more darker. So these are the poroid cells, and there is proliferation of poroid cells in the intraepidermal portion. This tumor is an example for Bose-Jadasson phenomenon, which is nothing but intraepidermal proliferation of poroid cells, intraepidermal manifestation of poroid tumors. So there are well-defined nests located in the stratum spinosum of an acanthotic epidermis. If you see this phenomenon is described in other tumors like Bowen's disease, Paget's disease, and seborrheic keratosis. Another tumor, benign tumor, is syringoma. Syringoma is a tumor of ecrine ducts. It is more commonly presenting in the lower eyelids and periorbital area. There are basically multiple skin-colored papules. Histopathologically, you will have two components, tubular cystic structures embedded in a dense sclerotic stroma. So these ducts are double walled, lined by, duct wall is lined by double cuboidal epithelium. And the differential diagnosis here is sclerotic basal cell carcinoma, desmoplastic trichoepithelioma, and microcystic adnexal carcinoma. We'll see later how to differentiate these three. The gene mutated is the SSH hedgehog pathway gene. Next entity is clear cell syringoma. If you recall, the three C's associated with ecrine and apocrine tumors, one of them is clear cell appearance, and one C is cuboidal or columnar cells, and another C is cystically dilated ducts. So in this tumor, we have these numerous ducts, symmetrical ducts, which are reaching higher up close to epidermis, and these ducts have a double layer of cuboidal or columnar cells with clear cytoplasm. The cytoplasm is having a clear appearance due to the accumulation of abundant glycogen in them. So this could be a potential diagnostic pitfall, as the clear cell appearance could be confused with metastatic clear cell tumors from kidney, thyroid, or lung. But in this condition, the ducts are symmetrical, and they have this comma tail appearance in them. And enzyme histochemical studies have shown that this tumor is rich in enzymes like succinic dehydrogenase and phosphorylase, which are markers of ecrine glands. And treatment of this is excision. Cylindroma, turban tumor or cradle cap tumor. You would have encountered this phenomenon. I mean, this tumor. You would have heard of this name very commonly. This is a tumor that presents a mosaic microscopic pattern, like a jigsaw puzzle-like pattern, and it has an hybrid occurrence with spiroadenoma, especially in Brooks-Spiegler syndrome. These are smooth flesh-colored tumors that are more common in the head and neck, particularly in the scalp region. That is why cylindromas of head are called as turban tumors. So, histopathologically, this picture is difficult to miss because of the typical mosaic jigsaw puzzle like pattern. This is one of the true ecrine tumors that shows this kind of a jigsaw puzzle like pattern, and it is hard not to miss this pattern and to diagnose it as cylindroma. So there is this jigsaw puzzle-like arrangement of bluish basaloid cells surrounded by a thick basement membrane with PAS positive reaction. Notice that around the sea of this blue basaloid mosaics, you have this thick, dense eosinophilic basement membrane. There are again two types of cells, central pale cells and peripheral dark cells, and they typically characteristically enclose these small ducts which help you to differentiate it towards ecrine differentiation. And this tumor is positive for CD117 and SOX10. Again, CYLD, cylindroma CYLD mutation is present in this tumor. The CYLD gene is a tumor suppressor gene located on chromosome 16. And it is also associated with Brooks-Spiegler syndrome, where there is multiple cylindromas and they occur in coexistence with spiroadenomas. Next tumor is hydradenoma papilliferum. It is a benign tumor arising from anogenital mammary-like glands. It is now classified under site-specific appendageal tumors in the new WHO. So, anogenital mammary-like glands. So, it is more common in the mammary glands and vulva, and that is labia majora or perineal region. In males, it can present in the perineal region or as an arm lesion. It is a skin colored papule and it measures few millimeter in diameter. So histopathologically, it is an adenoma with apocrine differentiation that explains the eosinophilic secretions, decapitated secretion. It is solid and cystic and there is a papillary pattern as the name suggests. There are tubular and cystic structures with papillary projections. There are two layers of cells, cuboidal and columnar cells with decapitated secretion surrounded by myoepithelial cells. And it is associated with human papilloma virus 16, 31, 33, 56 and 53. Next tumor is syringocystadenoma papilliferum. It is very common in head, neck, eyelids and mammary region. Grossly, it presents as an ulcerated bleeding papule or a wart-like appearance. Interestingly, there is an association with nevus sebaceous of Jadasson. It is an endophytic lesion which is cystic with papillary projections in the lumen. There are dual layer of cells, cuboidal, columnar cells surrounded by cuboidal cells. The stroma is characteristically rich in plasma cells, which helps you to differentiate it from hydradenoma papilliferum. And it has a connection with epidermis and follicular structures. It is invaginating, it is an endophytic tumor, so it is invaginating inside from the epidermis. Immunohistochemistry wise, BRAF V600E is positive in these tumors, and the pathogenesis of this tumor is mutation in mitogen activated protein kinase HRAS and KRAS. This is an interesting tumor which is typically pleomorphic adenoma as an adnexal tumor. That's all. It is the closest association between sweat gland tumor and salivary gland tumor. It is analogous to pleomorphic adenoma. It is more common in the head and neck. So when it is close to the salivary gland, it causes major confusion as to whether it is chondroid syringoma or a pleomorphic adenoma. Size wise, it is 0.5 to 3 centimeter. And like pleomorphic adenoma, you have both epithelial elements and a mesenchymal element. It is a benign tumor. It is well circumscribed, situated deep in the dermis and subcutis. And there are these epithelial structures which are represented by these ducts surrounded by myoepithelial cells, and characteristic basophilic mucoid or a chondromyxoid stroma, which is positive for Alcian blue histochemical stain. And this material is similar to chondroitin sulfate, which is similar to cartilage. And the mutation that is seen in this tumor is PLAG1, pleomorphic adenoma gene 1, which is a zinc finger proto-oncogene. It is the same mutation that is seen in pleomorphic adenoma. So it is positive for SOX10, calponin, P63, CEA and EMA is positive in the epithelial elements, and PLAG1 IHC also is positive in these tumors. This is the cytological appearance of chondroid syringoma, which is quite similar to what you see when you aspirate pleomorphic adenoma. There are these epithelial elements and myoepithelial cells. The myoepithelial cells may be plasmacytoid or epithelioid or spindled out in appearance, and they are usually scattered. In a fibrillary chondromyxoid stroma that is characteristically seen. This was a lesion that presented in the hand, and the cytological appearance was exactly similar to that of pleomorphic adenoma. We'll move on to the malignant tumors, porocarcinoma, which may present de novo or secondary to poroma. It presents with rapid growth, ulceration, and bleeding. This is from an article that is mentioned here. This is ecrine porocarcinoma arising from a pre-existing ecrine poroma of the scalp after radiotherapy, secondary to radiotherapy. So likewise, in histopathologically, as it is a carcinoma, it is poorly circumscribed, infiltrating, and you see that there are these nests of blue basiloid cells which are highly infiltrating. There is intradermal proliferation with atypia and increase in mitosis and necrosis. There may be squamoid, sarcomatoid differentiation also. Ductal structures are entrapped in between subtly, which are highlighted by CEA and EMA if there is any confusion as to whether it is a tumor of a poroid origin. And porocarcinoma, like ecrine poroma, is not immunohistochemistry positive. The regional lymph node metastasis is 57% in porocarcinoma. Next tumor is hidradenocarcinoma. It is a malignant counterpart of nodular hidradenomas. So it presents as a solitary nodule on head and neck and distal extremity. Microscopically, this tumor has large areas of irregular asymmetric and infiltrative growth with areas of necrosis. And you can also have clear cell change in these tumors, thus mimicking metastatic other clear cell tumors of kidney and lung. So this tumor has a high metastatic potential to regional lymph nodes, bones and viscera. Microcystic adnexal carcinoma. It is an infiltrative carcinoma which is most often confused with benign tumors because of the bland morphology. The morphology of the tumor is very bland, like a benign tumor, but its infiltrating nature makes it suspicious for you have to look for the infiltrative nature to call it a carcinoma, and the desmoplastic stroma and all to call it a carcinoma. It is a tumor with follicular and sweat duct differentiation. It is present in central face, upper lip, and nasolabial fold. Histopathologically, it is an infiltrative tumor with cords, strands, and nests of cuboidal cells with bland appearance. You see that there are these nests of bland ducts, which have a relatively bland appearance, but are irregular and infiltrating into deep dermis and subcutis. And if you look at the stroma, it is desmoplastic with areas of hyalinization. There is a single file appearance like lobular carcinoma of breast, which makes it suspicious for carcinoma, which is a pointer towards identifying it as a carcinoma. As usual, CAA and EMA highlights the ducts. P63 may be present. PHLDA1, which is a follicular stem cell marker, it will have a variable expression in these tumors, as it is tumor of both follicular and sweat duct differentiation. Underlying bone involvement may be seen. Though it is an indolent tumor, it is a locally aggressive tumor, so underlying bone may be involved. It is important to study this tumor because it is a tumor, Adnexal tumor, that makes it suspicious. I mean, the differential diagnosis is metastatic glandular tumor, adenocarcinoma from other sites, especially breast, because of the single file infiltrating appearance and bland morphology. It is confused with metastatic mammary carcinoma and so on. So that is why it is important to identify these features, and in such a case, immunohistochemistry may help, and other correlation, imaging correlation to rule out breast carcinoma and all may help. Digital papillary adenocarcinoma, it is another malignant tumor of ecrine and apocrine origin, which is presenting, as the name suggests, is more common in the acral sites, fingers, toes, palms and soles, hands more than feet. And it usually has no ulceration and is a deep-seated nodule, clinically mimicking a ganglion or cyst. Histopathologically also, it appears to be relatively circumscribed with cystic areas, and it is a solid cystic tumor with true as well as pseudo papillary structures. There are fused back-to-back glands with cuboidal or columnar cells with apocrine secretions. Myoepithelial cells may be present in the periphery, and these are usually relatively well circumscribed. If you look closely, there are these areas of squamoid differentiation and entrapped ducts in between, which is a marker of ecrine tumor. And these tumors have potential for local recurrence and metastasis, and it is associated with human papilloma virus 42, which is a non-oncogenic virus. Next most important tumor is nut carcinoma of adnexal tumor. Different from the nut carcinoma that is seen elsewhere. It is seen in lower limb, hand, shoulder and trunk. Histopathologically, there are sheets of epithelial cells with vesicular chromatin and prominent nucleoli with ducts and foci of abrupt keratinization. IHC wise, this tumor is positive for cytokeratin 5R6, P40, SOX10, and CA and EMA highlight the ducts, and NUT M1 is positive. So there is a fusion between NUT M1 and bromodomain containing protein 3 or 4, and there is this nuclear receptor binding set domain 3 fusion also. Differential diagnosis is porocarcinoma, because NUT M1 can be seen in both porocarcinoma and nut carcinoma. And but if you look at the morphology, how you will notice how different it is from porocarcinoma, which appears very blue, and nut carcinoma cells are appearing more vesicular in nature. Next is the endocrine mucin producing sweat gland carcinoma, which is a low grade mucin producing neuroendocrine neoplasm without any history. If you look at this, it appears to be cribriform ductal carcinoma in situ of breast. So endocrine mucin producing sweat gland carcinoma has such an indolent appearance that it appears like another breast carcinoma, DCIS of breast. It is a relatively well circumscribed tumor, usually with cribriform architecture and polygonal cells with amphiphilic cytoplasm and extracellular mucin that stain with PAS or mosaic carmine. IHC wise, it is positive for insulinoma associated protein 1, ER, PR, and all. Next is the adenoid cystic carcinoma of eccrine glands, which has the similar appearance like that of a salivary gland tumor. Another relationship between salivary gland tumor and eccrine tumor. It is a very infiltrative malignant neoplasm, usually seen in scalp. There are two types of cells, ductal cells and myoepithelial cells, and basophilic mucinous material that is similar to that seen in adenoid cystic carcinoma of salivary gland. And likewise, it also has perineural invasion and MIB gene activation. IHC wise, it is positive for CD117. Next is another interesting entity, which is apocrine carcinoma. It is similar to mammary ductal carcinoma, again with all this cribriform architecture, eosinophilic cells, decapitated eosinophilic secretions that are positive for PAS, and myoepithelial cells will be lacking in some places and may be present in some places. So it is a very confusing entity because the way it presents, it usually represents metastatic breast carcinoma. I mean, it is confused with metastatic breast carcinoma because of the morphological appearance, and also the site wise, it is usually seen in axilla. So whether it is de novo breast carcinoma of axillary tail or it is an apocrine carcinoma of the axillary region is a big diagnostic pitfall. So it has abundant eosinophilic vacuolated cytoplasm, and IHC wise it is positive for CK5R6, ER, PR, and gross cystic disease fluid protein 15 and mammoglobin. So differential diagnosis wise, most important thing is to differentiate between syringoma and microcystic adnexal carcinoma, because one is a benign tumor and other one is a malignant locally aggressive tumor. But both will have histologically bland appearance, and that is why it is important to differentiate both. Syringoma usually has a smaller size. Microcystic adnexal carcinoma has a larger size. Syringoma is usually present in superficial dermis, whereas microcystic adnexal carcinoma is highly infiltrative and it is extending to the subcutaneous tissue also. Syringoma is symmetrical, whereas microcystic adnexal carcinoma is asymmetrical. There is lack of prominent horn cyst formation and single file formation in syringoma, whereas single file formation is rampant in microcystic adnexal carcinoma. It is from the same article, A Practical Approach for General Surgical Pathologists, that highlights beautifully the difference between syringoma, morphiform basal cell carcinoma, and desmoplastic trichoepithelioma. Without the caption, you will think that these three are same tumor, that is syringoma. However, differentiating these entities from each other and from microcystic adnexal carcinoma is very challenging. So, deep infiltrative growth is a main factor that distinguishes microcystic adnexal carcinoma from syringoma and desmoplastic trichoepithelioma. This is another common diagnostic confusion between cylindroma and spiroadenoma. Cylindroma, like I said before, this typical jigsaw puzzle appearance, blue cells that are molded into one another like pieces of jigsaw puzzle with a very eosinophilic basement membrane, makes it difficult to miss the diagnosis of cylindroma. Whereas in spiroadenoma, you have these pale cells surrounded by dark cells and this subtle lumina in between and lymphocytes in the stroma. Next important differential is between apocrine carcinoma of skin and metastatic apocrine carcinoma of breast. It is the most difficult thing to differentiate between these two entities because they are two strikingly similar entities, and also apocrine carcinoma of skin usually occurs in axilla, anogenital region, or in the mammary, around the mammary glands. So it becomes almost impossible to distinguish both these entities. However, there are few subtle indicators that help you to differentiate these two entities. In apocrine carcinoma of skin, you have presence of neoplastic glands high in the epidermis, and you can look for evidence of transition from normal apocrine glands near tumor, and these tumor cells are rich in iron granules. If you look at metastatic apocrine carcinoma of breast, it is strongly positive for adipophilin, which is negative in apocrine carcinoma, primary apocrine carcinoma of skin. And apocrine carcinoma of breast has strong expressivity for HER2/neu, whereas it is not so much expressed in apocrine carcinoma of skin. Mammoglobin is variable expression in both the tumors. However, it is likely to be strong and diffuse in apocrine carcinoma of skin, whereas it is weaker in apocrine carcinoma of breast. So both the markers CK5/6 and P63 are not of much help in both the differentiating both the tumors. What are the immunohistochemistry that will help in case of ecrine and apocrine tumors? There are few which we saw with each entity. However, the CK7 and CK5/6 are positive in ductal cells that are entrapped in between the sheets of blue cells. Calponin, Soxten are myoepithelial markers which are positive in the myoepithelial cells in the periphery. EMA and CEA helps to highlight the lumina of entrapped ducts which are difficult to pick up in case of any doubt. BRAF V600E, to once again to recapitulate, is positive in syringocystadenoma papilliferum. NUT1 is expressed in poroma, porocarcinoma, and nut carcinomas. MIB and CD117 are strongly expressed in adenoid cystic carcinomas. Molecular findings. Each tumor has a molecular signature associated with it. In cylindroma and spiroadenoma, we saw CYLD mutation. In syringocystadenoma papilliferum, we saw BRAF V600E and HRAS. In poroma, we saw this YES-associated protein 1 and MAM-AL2, and YAP1, YES-associated protein 1, and NUT1, nuclear protein of testis M1 gene fusion. In mixed tumor or chondroid syringoma, we saw PLAG1 gene, which is pleomorphic adenoma gene 1. And in malignant tumors, we saw porocarcinoma has the same mutation as that of poroma, and digital papillary adenocarcinoma has again BRAF V600E. Adenoid cystic carcinoma had MIB NF1B fusion. Endocrine mucin producing sweat gland carcinoma had a heterogeneous mutation affecting DNA damage repair genes. And apocrine carcinoma has ERBB2 gene amplification. Once again, to highlight poroma, this is the NUT1 expression, IHC expression in poroma. So this is again an interesting article which I have quoted in both the previous two lectures. This article is free access, and please read through this article to get an idea about molecular signature associated with each tumor. So in poroma, we had this YAP1 NUT M1 fusion, NUT expression, and YAP1 MAM-L2 fusion. All these will activate the hippo S associated protein pathway, and in sporadic forms you had this mitogen activated protein kinase pathway. All of these will lead to poroma, and in these tumor suppressor gene, if there is loss of function, it will lead to porocarcinoma. And once again, in spiroadenoma cylindroma, we saw the CYLD, which is a tumor suppressor gene located in chromosome 16. If it leads to, if in the loss of function of CYLD gene, it leads to activation of nuclear factor kappa beta pathway, and the transcriptional activation will lead to tumors such as cylindroma and spiroadenoma. So, the most important syndrome that is associated with sweat gland tumor is Brooks-Spiegler syndrome. It is also known as CYLD cutaneous syndrome. It is an inherited autosomal dominant tumor associated with multiple spiridinomas, cylindromas, spiridinocylindromas, and trichoepitheliomas, and a rare salivary gland involvement. The mutation here is a germline pathogenic variant in CYLD gene, which is a lysine 63D ubiquitinase gene, which is a tumor suppressor gene located in chromosome 16, usually presents as multiple coalescing papules seen in head and neck. And it is also associated with salivary gland tumor, and the common salivary gland tumor associated with this is basal cell adenoma of parotid gland. There is an entity multiple familiar trichoepitheliomas, which is a phenotypic variant of Brooks-Spiegler syndrome, which is associated with multiple trichoepitheliomas, as the name suggests. So, with this, we come to the end of this discussion regarding ecrine and apocrine tumors. Just a small fun trivia. We have seen so many entities that it is hard to remember each and every one of them. But if you remember subtle morphological clues associated with each tumor, you can easily pick up and diagnose the particular entity. So here I'm showing two pictures. Take a moment or two to guess both these tumors. Just look at the morphological description of this. What do you see here? There are these ductal structures in a very sclerotic or fibrotic stroma. These ductal structures are embedded in the stroma, and some of these ducts have a double layer of cuboidal cells with eosinophilic secretion in the lumen, and some of them are having a comma tail like appearance also. So what could this tumor be? What is this pattern? And what could this tumor be? This pattern is ductal pattern, and this, if you recall, the tadpole or paisley tie pattern. And this tumor, if you look at this, it is just a sheet of, it's a blue sheet, and there is this vasculature, and if you look very closely, there are these small ductal structures enclosed in these, between these blue sheets of blue basaloid cells. And if you look from the low power itself, there are some pale cells in between, and there are dark cells in the periphery. There are these dark cells in the periphery, and relatively in the center you have pale cells. So what is this pattern and what is this tumor? This pattern is a sheet of blue basaloid cells with entrapped ducts, small minute ducts, and seem to be connected with the epidermis. So what could this tumor be? So the first tumor which we saw, tubular ducts embedded in a collagenous stroma, comma-like tails, granular eosinophilic material in lumen. Diagnosis is, you guessed it right, it is syringoma. And this tumor, anastomosing bands of epithelial cells arising from epidermis comprising poroid cells with enclosed lumina in between. Diagnosis, you are right, it is poroma. So these are the references. Thank you so much for giving me this opportunity.